Today we will be looking at the rest of the appendicular skeleton. What we already covered so far in terms of the appendicular. In the previous lecture, we covered the upper extremity. In the upper extremity, we did the clavicle, the scapula, the humerus. Then we moved down to the forearm where we did the radius and ulnar. And then we moved down into the hand where we did the carpal bones, the metacarpals, and the phalanges. So we did the entire upper extremity. Today, we will be looking at the lower extremity. We'll be starting with the pelvic girdle up here. We'll talk about the os coxa bone. Then we'll move down to the longest bone in the body, the femur, the patella, which is the kneecap. Then we'll move down to the leg, where we'll cover the medial bone, the larger leg bone, which is the tibia, then the lateral leg bone, the thinner, smaller one, called the fibula. And then we'll move down to the ankle, where we have the tarsals, metatarsals, and the phalanges. And that should sound a little bit familiar because when we did the hand, remember the hand had carpals, metacarpals, and phalanges. The foot has tarsals, metatarsals, and phalanges. In the forearm, we had two bones. In the leg, we have two bones. In the arm, we have a long singular bone. And then in the thigh, we have a long singular bone, right? So there's a lot of similarities between the upper and lower extremity. One of the big differences between the upper and lower extremity is when we look at the elbow joint, right? The elbow can flex and can extend, as does the knee, right? The knee can flex and extend, but the direction in which it flexes and extends is different. Right? When you flex the elbow, your hand comes forward. When you flex the knee, the foot goes backwards. So they both flex and extend, they just flex and extend in opposite directions. And the reason for that is that embryologically, the way the elbow moves is the same way the knee joint moves initially in embryological development. But what happens is as the baby is developing, the entire lower extremity internally or medially rotates. So what's in the back becomes in the front, and what's in the front rotates to the back. And that's why flexion and extension happen in opposite directions. Okay. So we're going to start with the os coxa, which is this purple bone here. And what you'll see is that the os coxa is composed of these three bones, right? The ilium, which is the largest, the pubic bone, which is anterior, and then the ischium. Then these three bones, the ilium, the ischium, and the pubic bone, they ankylose. And what I mean by that is when I say they ankylose, they fuse. And when they fuse, they form two things. They form this dish right here, this deep vinegar bowl, they call it, which is the acetabulum or the acetabular fossa. And it forms this large hole, the largest foramen in the body, called the obturator foramen. So you'll see down here, here is that large bowl, the ball and socket, called the acetabulum. Sometimes it's called the acetabular fossa. And then here's that large hole down at the bottom called the obturator foramen. Here is the large ilium. This entire section up here is the ilium. This section in the front is the pubis or the pubic bone. And then this portion in the back is the ischium. Those are the three main bones. Now, when we look at the os coxa, the very, very top of it, the top portion, is called the iliac crest. Okay, this is the iliac crest. It's kind of like where your belt would rest. The belt line is the iliac crest. And when you follow the iliac crest anteriorly, it takes you to a prominent little bump here. And when you follow it posteriorly, it's going to take us to this little bump. And these prominent structures in the front and in the back have unique names. The bump in the front, since it's in the front and it's on top, it's called the anterior superior iliac spine. If we go to the back, there's a posterior superior iliac spine. So again, you find the iliac crest, go anterior. How do you know you're going anterior? That's where the pubic bone is. The pubic bone is anterior. So anterior superior iliac spine. I will abbreviate when I talk about it. I usually say the ASIS. You cannot abbreviate on your exams. You have to write out the entire thing. So ASIS, anterior superior iliac spine, PSIS, posterior superior iliac spine. When we drop inferior to that, there's another prominent structure. And again, remember I used the word inferior. I dropped inferior. It's still anterior, but it's inferior. So it's called the anterior inferior iliac spine. So there's an anterior superior iliac spine and an anterior inferior iliac spine. Same thing holds true on the posterior side. There's a posterior superior iliac spine, and then there's a posterior inferior iliac spine. So there's a PSIS and a PIIS. There's an ASIS and an AIIS. Again, I can abbreviate, but make sure you guys use and write it out if you're ever asked that on an exam. Okay. All right. So iliac crest, and then the ASIS, PSIS, AIIS, PIIS. We did the acetabulum or acetabular fossa, and then we did the obturator foramen. What else do we have here? On the posterior side, right, this is the entire bone is the ischium, but this roughened section down here on the bottom that all of us are sitting on right now, this is called the sit bone because it's the point that makes contact with your chair. It's called the ischial tuberosity. The significance of the ischial tuberosity, all these tubercles or tuberosities or trochanters, or these are all bony attachment sites for muscles to attach. And the reason why we're doing osteology and learning all of these landmarks is because we will be moving on very shortly to muscles, and muscles have to attach to bones. So in progression or in sequence, we have to learn the bones and specific parts of the bones to understand where the muscles attach. Because when we do muscles, it's not just being able to identify the name of the muscles, but there are certain muscles that you'll have to know where they originate or where they insert. And of course, that would be related to osteology, to bones. So here, the ischial tuberosity, this is where your hamstring muscles originate. Your hamstring muscles are on your posterior thigh, or you can feel them on the posterior femur, but they originate right here on the ischial tuberosity. The reason why the ASIS is an important landmark is there's another muscle that originates here, and it's the longest muscle in the body. That longest muscle in the body is called the Sartorius muscle. It's called the Sartorius muscle. On the AIIS, the anterior inferior iliac spine, There's another muscle that originates here. It's one of the 4 quadricep muscles. Now your quads, or the quadriceps, are on the front of the thigh. And there are 4 of them. 3 of them have the word vastus in it, like vastus lateralis, vastus intermedius, vastus medialis. And the 4th, because it's called quad, so it must be 4 muscles, the 4th is called the rectus femoris. And the rectus femoris originates here on the AIIS, and it crosses the hip and it crosses the knee joint, because your quads, generally speaking, will be responsible for extending your leg. Leg extension is if you're kicking a soccer ball, that is leg extension, okay? Okay, now here's the ischial tube. We said the hamstrings originate there. Now superior to the ischial tuberosity, if we move proximal to it, right there, there's another structure called the ischial spine. Don't confuse the ischial spine with the ischial tuberosity. They're different structures. The ischial tube is much, much larger. The ischial spine is like a pointy structure right here. The significance of it is that it separates the greater sciatic notch, which is this loop, from the lesser sciatic notch, which is down here. So you have a greater and lesser sciatic notch, and what separates the two is the ischial spine. Now you can tell by the name of the structure, right? What is it that travels through the greater and lesser sciatic notch? Well, that would be the sciatic nerve. And this is where alignment comes into play, because alignment of the pelvis and sacrum is critical. If you have too much of an anterior pelvic tilt, too much of a posterior pelvic tilt, it changes the orientation of the greater and lesser sciatic notches, and that can rub up against the sciatic nerve, creating a form of sciatica. Okay, so up here is the ilium. Down here was the ischium, and it had a few parts, right? The ischial spine and ischial tube, and then the ischial ramus. And then more anteriorly is the pubic bone, and you have these tubercles in the very tip of it, right? There's the pubic tubercle. Now, on the anterior portion, same structures, but you can tell the difference between the looking at the pelvis from the lateral perspective, right? This is lateral because that's where the hip joint is. That's the acetabulum. And the lateral part of the ilium is much rougher. When we look at it from the medial aspect, looking inside the os coxa, or that pelvic bone, it's much smoother here. The smoothness is the iliac fossa. This entire structure in here is called the iliac fossa. Here's the pubic bone, and the medial section of that is the location of the pubic symphysis. What does that look like? We'll get to it in a second. Let's just move forward again. Let's just do a quick review. So we have the 3 parts of the os coxa: the large ilium, ischium, and pubic. They ankylose and fuse. They form the acetabulum and the obturator foramen. When we look at the main structures from the lateral view, we can see the iliac crest, anterior superior iliac spine, anterior inferior iliac spine. Follow the iliac crest to the posterior, posterior superior iliac spine, posterior inferior iliac spine. Here is the ischial spine with the greater and lesser sciatic notch. Here's the acetabulum, obturator foramen, ischial tuberosity, ischial ramus, pubic tubercle, superior ramus of the pubis, inferior ramus of the pubis. Again, superior and inferior ramus of the pubis. When we look at it from the medial perspective, we could still see similar structures. There's the iliac crest, anterior superior iliac spine, anterior inferior iliac spine. Here is the pubic bone. So this is the location of the pubic symphysis. The very tip of it is the pubic tubercle, obturator foramen, ischial spine, greater sciatic notch, lesser sciatic notch, and then back here and underneath is the ischial tuberosity. When we look at it from the front view and we bring it together, now you can see when I talked about looking at it from the lateral view, which would be here, or looking at it from the medial view, looking inside out. The inside surface is very smooth. That's the iliac fossa. The significance of this iliac fossa is that this is where the iliacus muscle originates. The iliacus is a primary hip flexor, right? If you want to lift your hip up, right, so that you can climb stairs, that is the responsibility of the iliacus. So there's the iliac fossa. The top of the iliac is the iliac crest. Right here is the ASIS, and then down here, the AIIS. On the posterior side, we know it's the posterior because you could see the median sacral crest and the sacral hiatus here. Here's the posterior superior iliac spine and the posterior inferior iliac spine. Here's the sacroiliac joint on the anterior, your SI joint, sacroiliac joint, where the sacrum and the ilium come together. And on the posterior side, there's a little bit of overlap due to that ilium and the iliac crest, but it would be the indentation that we see here. Here's your sacrum, S1, 2, 3, and 4. And then here's the coccygeal segments. There's usually 3 to 5. Here's the pubic symphysis. It's kind of like here's a vertebral disc. It's horizontal. Here's another vertebral disc. The pubic symphysis is vertical, but it's made up of the same stuff that a disc is, right? It's fibrocartilage, the strongest cartilage in the body. Here's the pubic tubercles. The pubic tubercle is where the inguinal ligament attaches. So there's a ligament. If you ever look at those older Calvin Klein commercials where there's that gentleman that has the chiseled out abs and those lines that go kind of obliquely inward, that's the inguinal ligament. It runs in this direction, this way, okay? And it runs this way. From the ASIS to the pubic tubercle. That would be the area for the inguinal ligament. Okay, again, here are the 3 main parts. Here's how everything looks when it's put together. So you can see here's the os coxa made up of the ilium, the pubis, and the ischium. In the center is the sacrum and the coccyx. Here's your SI joints. Here's the base of the sacrum, iliac crest, ASIS, AIIS. Acetabulum. The pink is the pubic bone. The yellow is the ischium. Same structures, nothing new, just labeled. Again, you can see the iliac fossa. Here's the L5 vertebra, which is the last vertebra for most people. And I say for most people because on occasion in my career, I have seen 6 lumbar vertebrae. I've seen extra vertebrae. It's an anomaly, but they do exist. You can see the acetabulum, pubic tubercle, obturator foramen, pubic symphysis. Here's the ischium. Here's the pubic bone. Here's the AS-IS and the AI-IS. On the posterior side, here's the iliac crest, PSIS, PIIS, ischial spine, greater sciatic notch, lesser sciatic notch. The roughened ischial tuberosity, which is where your hamstrings originate. These are the sacral foramina, the holes. Here's the coccyx, which is anywhere to 3 to 5 fused sacral segments. Here's your L4, L5 vertebra. And the top of the iliac crest for most people is at the level of around L5, around the same level. The PSIS is typically at the level of the second sacral tubercle and the second sacral foramina. And there's typically dimples that are here, right? If you ever go to the beach or to a public pool and people are wearing bathing suits and you see the waistline of the bathing suits dip down a little bit, sometimes if people wear bikinis or the boxers drop down just a little bit, you'll see that on most people, there are these 2 dimples, right? One here and one here. Those dimples are created by the accentuated PSIS and then the dipping in here of the sacroiliac joint. It is a major palpatory landmark that in manual medicine, it's one of the things that we feel for when assessing for pelvic alignment and for smoothness of movement at the sacroiliac joints, because there is some gliding movement that should take place there. One of the things I want to point out to you is there is a difference between a male and female pelvis, setting aside identity or how someone may identify as male or female. There's still the reality of the bone structure and biology. So when we look at, when they find a fossil of a human being, right, it's just the remnants. So they're not going to be able to look at fossils and say this individual identified as a male or identified as a female. They would be looking at the fossils or looking at the bones and saying, was this biologically a male or a female? And the way that you differentiate between the two is by looking at the bony structure and the articulations. So if we look at the male pelvis and the female pelvis, which one appears to be more prominent and larger and heavier? Well, that's going to be the male. And that may be due to muscular structure, the muscle density is a little bit thicker, but we also look at the effect of hormones like testosterone is going to make the bony structure thicker. But the second thing that we look at is pay close attention to this angle right here. If you pay attention to the angle down here at the bottom, inferior to the pubic symphysis, you're going to see that the angle formed is typically less than 90 degrees on a male pelvis, and on the female, much wider than 90 degrees. And that's because the pelvic, this inlet right here, and the outlet has to be larger on a female than it is for a male for one major difference, right? Think about it. Biologically, a woman can carry a baby, a male cannot. So here, this gap in this opening has to be able to hold and pass a baby through here. So this is one of the major differences between the female pelvis and the male pelvis. When we move inferior to that, now we look at the longest bone in the body. Now we're looking at the femur. Now the femur has some landmarks to it. Notice that when we look at it from the anterior, the shaft is very round, cylindrical, and it's smooth. But on the posterior surface, there's this sharp line or this ridge in the back. You don't see the line in the front. We only see that line, this ridge here on the posterior, and that's called the linea aspera. So that's one of the ways you can tell if you're looking at the femur from the anterior aspect or the posterior aspect. The other is if you look down at the distal end, it looks very different, right? The distal end on the posterior, you can see the lateral and medial condyles. You can see that nice rounded contour to them. You don't see it as much on the anterior. You can still see the medial and lateral condyles. You just don't see the smoothed out rounded surface as you do in the posterior. Okay, here is the head of the femur, the neck of the femur. And then remember back in when we covered the upper extremity and the humerus, there were greater and lesser tubercles. Well, in the femur, there's a greater and lesser trochanter. And again, just like the greater and lesser tubercle, there are muscles that attach. There are major muscles that attach to the greater and lesser trochanter. The gluteal muscles attach to the greater trochanter, like the gluteus maximus, the gluteus medius, and the gluteus minimus. The iliacus and the psoas major, known together as the iliopsoas muscle, attaches to the lesser trochanter. And the iliopsoas is a major, major, major hip flexor. Connecting the greater trochanter to the lesser trochanter is the intertrochanteric line, the intertrochanteric line. You could still see the same structure on the posterior. You could see the head, the neck, the greater trochanter and lesser trochanter, and connecting the two is the intertrochanteric crest. In the front, it's the intertrochanteric line. On the back, it's the intertrochanteric crest. On the head, at the most proximal or superior part, there's an indentation, like a concavity, a little depression. That depression is called the Fovea Capitus. The depression is for a ligament to attach to, a ligament that goes from the head of the femur to the acetabulum, and it helps to stabilize the joint. Then we have the shaft. When we move distally, you can see there is a medial condyle, and above it, a medial epicondyle. And above that, there is a tubercle called the adductor tubercle. And the adductor tubercle is an attachment site for an adductor muscle that we will cover when we cover the next bit of information, called the Adductor Magnus. It's a very, very large, powerful adductor, as you can tell by the name, Adductor Magnus, like magnum, huge. So medial condyle, medial epicondyle, and way up at the top, an adductor tubercle for the Adductor Magnus to attach. Okay, the medial and lateral condyles are going to articulate and form a joint with the top of the tibia, which is the lower leg bone. Okay, again, looking at the posterior part of the femur, the difference on that posterior side again is the linea aspera, that line. That's where your quadricep muscles, some of them are going to originate. Lateral condyle, medial condyle. How do we differentiate medial from lateral? Find the head of the femur. The head of the femur points medially. It points inward. So on that head side is the medial condyle and medial epicondyle. Okay, the head of the femur projects medially. Why? Well, just look at the picture. It projects medially to attach to the acetabular fossa or acetabulum. And then the tibial condyles are going to articulate with the tibia. And you can see the patella right here. That patella is going to, or the sesamoid bone or the kneecap is going to articulate right here where it says patellar surface. This needs to be very, very smooth. Otherwise, what happens is you get a lot of clicking. When you flex and extend the knee, this becomes rough, and it can become rough if, let's say, a person has flat feet and they have pes planus for flat feet, that medially or internally rotates the tibia. When it rotates the tibia medially, it torques and changes the orientation of the quadriceps muscles as they cross over the kneecap and attach to the tibial tubercle. It changes that direction of the pull, and it creates this torque or torsion of the patella, and it can misalign the patella in this articulation, and over time you get this improper tracking of the patella within this patella surface. And this is where people get this clicking and grinding and popping all the time. So a lot of people don't think about the feet as it relates to the knee. But over my 25-year period in healthcare, I have found many meniscal tears, the meniscus of the knee, stemming from pes planus or flat feet. And then we would get that person a customized orthotic that's made at a laboratory. They're soft, they're flexible, they're not the hard plastic, uncomfortable orthotics, but soft and flexible. We insert them in their sneakers or their shoes, or they make them today. I use a company that even makes flip-flop orthotics where they're customized orthotics and they're waterproof and everything. They lift up the foot, takes out the rotation of the tibia, and can help the knee, the hip, and the entire spine. Tremendous. Very, very beneficial for people. So whenever there's knee pain or hip pain, we have to go to the most distal joint, which is the foot, to analyze it. Okay, because remember, when you step on a dog's tail, it barks at the mouth from pain. And many times you have joints that can bark with pain, and it comes all the way from the other end, right? So we have to look at all the joints. Okay, let's take a closer look at that linear aspera on the posterior side. Again, you can see that ridge on the back. The depression behind the knee is called a popliteal surface. When you hear the word popliteal or popliteal fossa, it's the depression behind the knee. Okay, you can see a nice look at the lateral and medial condyles. Here's the intercondylar fossa, the intercondylar fossa. It's between the lateral and medial condyles. Go up and you got the lateral and medial epicondyles. Above the medial epicondyle, adductor tubercle. Here's the kneecap or the patella. And when we look at it, the ventral side, the posterior side is much, much smoother than the anterior side. The anterior side of the kneecap or the patella looks very, very rough, and that's because the quadricep muscles are going to cross over this on their way to attaching to the tibia bone. The base is the top part, and the apex is the inferior part. And if you think of base and apex, right, if you look at a mountain, most people think that the base is the bottom, the apex is the top, and that's true. but the apex is the pointed part. The base is always the widest part. So the base in this point is the top, and the apex or the pointed part is the bottom. So the flip-flop of a mountain. Okay. This is the underneath surface, which has facets, and they're going to articulate to the patella surface on the femur. And when there's improper tracking, this starts to degenerate. And when it degenerates, you get arthritis of the knee joint. Okay, they call it chondromalacia patella. Chondromalacia patella is when they get this grinding of the knee. Let's look at the lower leg and look at let's look at the orientation here, and then we'll move to the separate bones. So when we look at the orientation, notice that the tibia is the most superior one, right? And this is the one that makes up the knee joint. Notice the fibula is inferior to it. It does not articulate with the femur at all, only the tibia, right? If we zoom in and you look, you can see the tibia makes up the knee joint, but not the fibula. The fibula is more important at the ankle. And I'll show you that in a second. So pay close attention. You see that the tibia is higher because it articulates with the femur. But if we look distally, notice that the fibula descends further distally than does the tibia. These two landmarks are important. It's the lateral and the medial malleolus. Those are the two parts that clasp a tarsal bone called the talus to make the ankle joint, to make your ankle dorsiflex and plantar flex. But notice that the lateral malleolus descends further distally than does the medial malleolus. And what this creates is this locking position where if you put your feet on the floor and you try and evert your feet, it's very difficult. But if you put your feet on the floor and you try and invert, that's much easier to do. It's much easier to invert and bring the soles of your feet together than it is to evert and bring the soles of the feet apart. And that's why when you slip down the stairs or you slip off a curve, what type of injury takes place is the foot drops, we call that plantar flexion, and the foot inverts. So you get this plantar flexion inversion injury. And that's where you get that horrible ankle sprain and all the ligaments on the outside of the ankle either tear or stretch, and you get all the swelling and black and blue on the outside of the ankle. So we call that a plantar flexion inversion injury. And that's because the lateral malleolus blocks the foot from everting. And since there's no bone blocking the inside, it's a lot easier for the foot to invert than it is for it to evert. Okay. Also pay attention to this little bump here on the front of the tibia, and that's called the tibial tubercle or the tibial tuberosity. Again, anywhere there's a tubercle or a tuberosity, muscles will attach. There are large, powerful muscles that insert here, and those are called the quadricep muscles. So your quadricep muscles are powerful, immense thigh muscles in the front of your femur. They cross over the patella, the kneecap, and then they finally insert right here to kick a soccer ball, right, to extend your leg. But in that same horizontal plane of the tibial tubercle, if we draw a straight line across, it takes us to the head of the fibula. There's the head of the fibula. Here's the lateral tibial condyle and the medial tibial condyle. Okay, let's look at, again, just from the anterior view. Here's the lateral, and here's the medial tibial condyle, tibial tuberosity, head of the fibula. When we go inferior and we follow the fibula inferior, it takes us to the lateral malleolus. When we follow the larger bone, right? Remember, you tell a small fib. You tell a small fib, so that's the smaller of the bones. So here's the larger tibia. Look at the anterior margin. That's very sharp. The anterior margin is very sharp, and that's why when you get kicked in the shin, let's say in soccer, it hurts so much because there's not much protecting those muscles, arteries, veins, and nerves from that anterior margin. So it really stings. And then here's the medial malleolus. The medial malleolus, lateral malleolus, they act as like a monkey wrench, right? If you look at a monkey wrench, they come, the head of a monkey wrench can open and close, but it's going to articulate. It's going to hold something down here in this joint at the bottom. What it's going to articulate with is the ankle, the talus bone of the ankle. Let's look at the posterior surface, right? So we're looking at the posterior view of the leg. And again, there's the medial and the lateral condyles. Here's the fibula and the head of the fibula. This is called the intercondylar eminence. This little point right here, here and here, that's the intercondylar because it's between the medial and lateral condyle. So it's intercondylar eminence. Here's a popliteal line. Popliteal line is a line for a muscle called a popliteus muscle. No big deal. Popliteus muscle. And again, you could see the lateral malleolus descending further down, further distally than does the medial malleolus. And as we mentioned before, that's why inversion of the foot is much easier and eversion is more difficult because the lateral malleolus blocks the movement. When we look at the foot from the bird's eye view, from superior looking down, here's the most superior bone called the talus. Now there are 7 tarsal bones. In the hand, there were 8 carpals, and in the hand, we learned 2 rows, proximal row and distal row. In the foot, there are 7 tarsal bones, and they're not arranged in those 2 rows. They're arranged differently. There are, however, 1, 2, 3, 4 of them are distally. And then these 3 are oriented posteriorly, but let's look at it a little bit differently. The superior bone, the highest up, that makes the ankle joint, it's going to articulate with the medial and lateral malleolus, that's the talus bone. And the trochlear of it is going to attach to the fibula and tibia by way of the medial and lateral malleolus. The most inferior bone is the heel bone, right? That's your calcaneus. That's the part of the foot that strikes the ground on heel strike when you're walking. So you have the calcaneus is the largest and it's the most inferior. The talus is the superior, and they call it the keystone bone because it actually attaches to all of the other tarsal bones. Okay, the navicular bone articulates with all the other tarsal bones. Anterior to the navicular bone are 3 cuneiforms. You can see cuneiform bones right here. There's 1, 2, 3. And they are called the medial, lateral, and intermediate cuneiform. Medial, intermediate, and lateral. Sometimes in some books, they also call it cuneiform 1, cuneiform 2, cuneiform 3. How are they named? 1, 2, and 3? Well, they're named after the metatarsal bone that they articulate with. Metatarsal 1, metatarsal 2, and metatarsal 3. Attaching to the 4th and 5th metatarsal is the lateral one in that proximal row, in the distal row. called the cuboid bone. So those are the 7 tarsals. You have 1, 2, 3, 4, 5, 6, 7. Talus, most superior. Calcaneus, the most inferior, and the heel bone. Navicular, which articulates with all the other 6 bones. Then you have medial cuneiform, intermediate cuneiform, lateral cuneiform, or cuneiform 1, cuneiform 2, cuneiform 3, and the cuboid. In the foot, they're tarsals. In the hand, they're carpals. In the hand, you had metacarpals. In the foot, we have metatarsals. Just remember T for toes, tarsals. Metatarsal 1 is on the great toe or the hallux side. Then metatarsal 2, 3, 4, and 5. Distal to that is where we have our phalanx or phalanges. There's a little typo here. This should say proximal and not proxima, just like this one, proximal. So there is a proximal, a middle, and a distal phalange. Proximal, middle, and distal. But on an exam, if you were asked, what is this bone, you would have to be very specific. You would say the 5th, like 5, TH, the 5th, middle phalange. If we pointed here, you would say the 5th distal phalange. If we pointed here, the 5th proximal phalange. If we pointed here, the 5th metatarsal. If we pointed here, the 2nd, right? You'd write 2 ND, 2nd proximal phalange, 2nd middle phalange, 2nd distal phalange. What about this? Remember, just like the hand, right? The thumb only has a proximal and a distal phalange. There is no middle phalange of the great toe or of the thumb. There's only a proximal and a distal phalanx. Okay, so if we asked what is this on a test, first metatarsal, 1ST for first metatarsal. Here, first proximal phalange. Here, first distal phalange. When you look at the foot from the medial perspective, right, here is the great toe. Again, you could see the great toe has a first metatarsal and then only a proximal and distal phalange. The other toes, you could see, if I zoom in a little bit, you could see there's a proximal, a middle, and a distal. Here is the talus bone, the most superior that makes up the ankle. Here's the heel, the calcaneus. Here's the navicular bone, and you can see the medial cuneiform. And then that's your first metatarsal. You can see there's a nice arch. What helps to maintain the arch is a band of muscles that goes from the calcaneus and it goes this way. Think of it as like a bow and arrow, right? If you hold it and you pull on the string, right? If you pull on the muscles, what happens to the bow? It becomes increased in its size, right? It really becomes arced. If you increase the tension on the muscles, you get an increased arc. If you decrease the tone and tension of the muscles, you get pes planus or flat feet. So flat feet is called pes planus. High arcs are called pes cavus. They both have their problems in life. If it's too high of an arc and the muscle tension is too great, you'll get muscle tension pulling on the calcaneus, and over time, you'll get a calcaneal heel spur. You'll get a bony growth coming off of the heel. And it becomes very, very painful on heel strike, on the gait cycle, right? On the gait cycle, there's heel strike, foot flat, and then toe off. Heel strike, foot flat, toe off. It goes through that type of phase. So there's ways of assessing foot structure these days. I know in my office, it's actually part of my initial exam. My patients stand on a thermographic 3D foot scanner, and it measures all the contact points on the scanner by temperature, thermography. and it can actually tell, it has a whole grading scale of the degree of ankle instability based on pronation. And then we simply would send that to a laboratory and they make these customized foot orthotics for my patients. Again, here's a close-up view of the foot. You can see the talus, the calcaneus, the navicular, cuneiform 1, 2, and 3, cuboid, metatarsal 1, 2, 3, 4, 5. And then you could see the phalanges, proximal and distal phalange of the hallux, proximal middle distal phalange of digits 2 through 5. And again, from the medial view, what's really neat about this is take a look. It's pretty cool. If you look at the talus, what prevents the talus from dropping all the way down is this bony structure right here. It acts as a shelf, right? It's a shelf that comes off of the calcaneus and it holds the talus up. It's pretty neat, right? This extension of bone holds the talus up so it doesn't drop all the way down. The navicular can drop and the cuneiform can drop and the rest of the forefoot can drop, but not so much the talus. The talus is prevented from dropping all the way down. It can move down, but it moves down in relationship to the calcaneus that's holding it up. So it can move a little bit, but not past this point, not that tubercle that comes off of the calcaneus here. Okay.